This is a presentation on frailty in the older adult patient. The definition of frailty has evolved greatly over the past 50 years. For much of the 20th century, people did not live long enough for frailty to become an issue. Frailty is generally considered a condition that afflicts the elderly, but it may be seen in those who have a large burden of chronic disease. Frailty has had a number of vague definitions throughout the years. Almost all of these descriptions allude to the notion that frail individuals are more likely to do poorly when compared to their non-frail peers. Only recently has the definition of frailty become more robust. Now it describes frailty as being an age-associated process and includes the concept that there is an associated decline in functional reserve. The frail individual is unable to cope with stressors because of the loss of total body reserve. It is this loss of reserve that leads to the increased mortality and morbidity seen in our frail patients. As shown on this slide, there are many features of frailty. Sarcopenia, or the loss of lean muscle mass, is the hallmark of frailty. Sarcopenia is pathological and is different from the loss of muscle seen with normal aging. It is due to inflammation, hormone imbalance, poor nutrition, physical inactivity, and muscle cell death. Chronic medical conditions such as cancer, diabetes, heart disease, and autoimmune conditions are thought to contribute to sarcopenia. The geriatric syndromes are a collection of disorders that are characterized by a group of signs and symptoms. These syndromes are multifactorial, and every patient may have a different pathway to the condition. For example, one patient may experience delirium following a change to their medication. However, another individual may have the same presentation of delirium, but from an entirely different cause, such as constipation. Much is the same for frailty. Two individuals may both be frail, but each has a number of different factors that has led to them being frail. Frailty is not as easily defined as other chronic medical conditions, such as hypertension or chronic obstructive pulmonary disease. Most chronic conditions can be reproducibly measured from one patient to another. Frailty, on the other hand, cannot be measured as easily. The most vulnerable individuals in our population appear to be those who are at the intersection of disease, disability, and frailty. Medical professionals are well versed in identifying disease and disability. It is now time to become better equipped at identifying frailty, and this process starts with screening. There are essentially two major schools of thought when it comes to measuring frailty. Kenneth Rockwood put forth the Frailty Index. Linda Fried's research focused on frailty as something that is physically measurable. The Frailty Index assesses 70 different wide-ranging conditions and functions. Several of the items on the index are diabetes, hip fractures, Parkinson's disease, falls, sleeping problems, ability to climb stairs, delayed recall testing, and depression. This theory rests on the idea that frailty will develop in individuals who accumulate enough medical problems and functional limitations. The Fried phenotype, or the frailty phenotype, is an objective scale for measuring frailty. Slow walking speed, unintentional weight loss of more than 5% in 6 months, low recreational calorie expenditure, self-reported fatigue, and a low grip strength are the 5 criteria evaluated by the frailty phenotype. Testing positive on 3 or more of these criteria is a positive test for frailty. This scale is slightly more challenging as it uses normalized data for walking speed, grip strength, and recreational calorie expenditure. It also requires appropriate space to measure walking speed, as well as a special device to measure grip strength, called a hand dynamometer. The strength of the frailty phenotype is that it has now become the gold standard for researching frailty. It is objective, and it does correlate well with patient outcomes such as hospitalizations and mortality. It is clinically intensive, as described earlier, which makes it more difficult for widespread screening within primary care offices. The Frail scale is a simple, easy-to-use scale that can be asked of a patient in under 30 seconds. It has been studied against the frailty phenotype, and it is comparable in identifying frail individuals. For providers working within primary care, this frailty screening tool is quickly administered and does not require any special equipment. Screening for frailty should take place when one or more of the following conditions is present. Medical conditions that lead to chronic inflammatory states, major organ dysfunction, or memory problems all contribute to frailty and should serve as reminders for screening. The earlier frailty is identified, the more likely something can be done about it. Resistance training is at the heart of the treatment plan for frailty. As mentioned before, sarcopenia appears to play a central role in the progression of frailty. Resistance training can help to reverse the loss of lean muscle mass. Resistance training can also help improve day-to-day performance with ambulation, reduce falls, and increase a person's overall functional independence. A supervised program is recommended since patients are at an increased risk for injury due to the very fact that they are frail. Diets rich in protein may also help to reduce the sarcopenia of frailty. This may require that nutritionally dense food be brought into the home by family members or outside agencies. It is also important to do a thorough dental exam to ensure that patients are able to physically consume these foods as well. Protein supplements may be considered on a case-by-case basis, but trying to get individuals to eat healthy and nutrient-rich foods should be the goal. Unfortunately, the benefits from a high-protein diet are only present while the nutritional support is there. After you have identified a frail individual, it is recommended that a comprehensive geriatric assessment be performed. Focus needs to be placed on recognizing other geriatric syndromes such as depression, dementia, pressure ulcers, etc. Many of the geriatric syndromes may be contributing to or be the cause of frailty, and vice versa. Polypharmacy, meaning greater than 5 medications, should also be reviewed. The indication of continued need for every medication should be extensively discussed with patients. Medications that are on the Beers list should also be reduced or avoided, if at all possible. Improving functional status of the frail individual may prove difficult, but enrolling in a Tai Chi program may prove beneficial for some individuals. Depression is common but treatable in most older adults. Untreated depression will likely prove to be a substantial barrier for successfully treating frailty in our older adults. Identify it using a validated tool such as the Geriatric Depression Scale, treat it, and help to reduce any of the social isolation that may be contributing to it. Frailty is a common, complex, and difficult to treat issue in our older adult population. We recommend that you remain vigilant to this condition, particularly as our older adult population continues to expand.